So I'll be talking about zonular dialysis. So as we all know, the most common causes are pseudoexfoliation, trauma, high myopia, connective tissue disorders, and most of the time iatrogenic. So here, I'm just removing or aspirating cortex, and sometimes when we are overzealously doing aspiration of cortex, you can grab the bag as well, and this is what happens here. So you can see the line of the zonular dialysis there. So I'm putting some OVD thinking, okay, let me stretch out the bag, but at the same time, the mistake that I'm making here is I've kept my infusion running. So I should have, as I've started injecting the viscoelastic, I should have just kept my IA probe there and stopped, putting more irrigation. So I managed to do that. I fill in some viscoelastic and then I try to take it out with slow flow, irrigation. But then I feel that I can see that the bag is coming out more. So at this point, fill in with viscoelastic, and my next option would be either to put a Chang capsule hook to give you counter traction at that focal area of zonular dialysis, or inject a CTR. So I fill the bag in, and I'm injecting the CTR in. And the trick here is to always inject the CTR first in the direction of the zonular dialysis first. Some CTRs, the CTRs will come saying right or left. Right or left doesn't mean right eye or left eye. It is the direction where the zonular dialysis is, where you're sitting. If the zonular dialysis is to your right, use the R. If it's to the left, use the L1. Okay, and so here we managed to put a lens in the bag. And, and when, of course, aspirating cortex, do it tangentially rather than radially. So, like it was alluded to before by Dr. Menumathan, used a lot of dispersive viscoelastic. And you can use Chang capsule hooks for counter traction if there is only focal zonular dialysis. Or you can always inject CTR, but inject it in the direction of the zonular dialysis first, and remove cortex tangentially to reduce zonular stress. Here is the next case. This is a wife of a consultant orthopedic surgeon who indulges in kickboxing, and she got kicked in the eye, and she presents with this, with vitreous in AC with zonular dialysis. And she needs a toric lens as well. So because I know that there is quite a bit of zonular dialysis, I'm preparing, for capsule hook placement first itself, and because there is vitreous, I stain the vitreous with triamcinolone. Vitreous in the AC is your enemy, but you don't want to remove too much of it, because then you lose the vitreous scaffold, and then the lens can fall back. So remove as much as possible, and then coat the area of the defect with dispersive viscoelastic, and use the soft shell technique or ProVisc or any other viscoelastic to push the viscoat onto that defect. So here you will find that the capsule is always very weak, when you try to initiate rhexis. So you can initiate it with the sharp needle or with your side port, which is which will give you the a flap. When you put iris hooks to the bag, wait for at least 2 or 3 clock hours after it goes past the area where you intend to put the iris hooks. Because if you put the iris hooks straight away and then you continue rhexis, within 1 clock hour it might run out. So wait for some time and then do it. I just do a standard phaco, and then I'm railroading Gore-Tex suture in the area of the defect, because my plan is to put a CTR with a single Cioni ring in this case. So what I do is I take out the needle 2 millimeters from the limbus, 4 millimeters apart. So, and then slowly slide the single Cioni ring in here. And then when you pull the sutures up, the Cioni ring slides to the area of the zonular dialysis. And you can either do a sliding slip knot or a 3-1-1, but always make sure to bury the knots of the Gore-Tex in, because you don't want to leave it out and get scleral necrosis and conjunctival erosion there. And then going on to and then always put triamcinolone at the end to look for any vitreous, and then finish off the case with myostat or myocol to look for a round pupil, just to make sure that you have no vitreous in the AC. Now going on to another case, this was again from blunt eye injury many years ago, and this is the size of her pupil. This is permanently dilated pupil, and she's got more than 6 to 7 clock hours of zonular dialysis here. So, and she needs a toric lens as well. And to make matters worse, she's got radial keratotomy incisions as well. So I know that I will be using CTR with the Sioni ring, or you can also use a capsule tension segment, the IMH segment. So because of that, I'm preparing conjunctival peritomy here. You need good diathermy, because when you make your sclerotomies, you don't want hemorrhage seeping into the vitreous cavity. Then you make your paracentesis as peripheral as possible. And when you make the incision, avoid the radial keratotomy incisions, otherwise they'll become, full thickness corneal gapes, and then it's almost like treating a corneal laceration. So now I'm initiating the rhexis with a side port needle, and then you can see the folds. What I do is I wait, because I know I'm going to put Chang capsule hooks in that area, so I just wait till I go past it by at least 1 or 2 clock hours and generously fill with dispersive viscoelastic as much as you can. And I put the Chang capsule hooks. The best part about the Chang capsule hooks in this case is because they support the lens all the way to the equator. And they're more forgiving than iris hooks, because sometimes if you pull the iris hooks too far, they can cause tears in the bag. Again, say I take it around more than 1 to 2 clock hours, put the 2 rings, and then proceed. You don't want to put the capsule hooks too close to the tearing margin of the rhexis, because it will then extend out. And take precautions to center the rhexis on the lens and not because you don't want an eccentric rhexis because of the zonular dialysis. Do gentle viscodissection or hydrodissection, and here is a straightforward phaco. But what happens is, pay attention to the Chang capsule hooks all the time, because when you're aspirating these nuclear fragments, sometimes the capsule hooks can disengage, and then you've got a free floating bag. And you will see that happening in my video very, very soon. And you want to avoid, as much zonular stress as possible. So everything is horizontal and not vertical movements here. And slowly you will find that, the hook at the top there becomes disentangled from the bag. So again, filling it with dispersive viscoelastic, and you can now see that this hook has come off from the bag, and the bag is almost floating or coming into my phaco probe as I'm taking out the nuclear fragments. And I'm thinking I can get away with it, but then I realize, it's better to be safe than sorry. So I go back in, put lots more viscoelastic, and then I re-engage the capsule hook, with the rhexis margin. So I do that, and then I now realize that there is almost 7 to 8 clock hours of zonular dialysis. So then I'm going to put another capsule hook to support it as well, and then proceed with the removal of the last fragment and the epinucleus shell. But between every step, you're making sure to fill generous viscoelastic. And always be careful with the last piece, like how Sunil and Dr. Minumathan showed. That's when you get post-occlusion surge, and then already the whole apparatus is floppy, then it can come out. So now do IA with tangential sweeps rather than radially stripping. And these capsule hooks provide very good equatorial support. So, you can get through the step very nicely, doing it in a very gentle and careful manner. So, again, I fill with OVD again. And now the next thing is I take a 25 gauge trocar and I make a sclerotomy 2 millimeters from the limbus. And these 2 sclerotomies are 4 millimeters apart. In the last case, I showed you the railroading technique, with the Gore-Tex suture. But from then on, now I've stopped railroading because you're passing it blindly. So now I'm taking a Sioni ring and passing the Gore-Tex suture onto the eyelet of the Sioni ring. And I just place the Sioni ring in, you dial it in. And you always, again, have to have a thoroughly inflated bag because you don't want folds as it is going in. So you have to take care to position the eyelet of the Sioni ring above the capsule because you don't want it to be underneath the capsule. It has to be above the capsule. And now, once the Sioni ring is in, then I can breathe easy. So what I then do is I take out the sclerotomies, and with using a max grip forceps, I just pull one end of the suture. And you can pull any end. You don't have to go, either or. Once you pull one end, then you can always pull the other end, and it threads it around the eyelet of the haptic. So the advantage of this technique is you're not railroading blindly with any suture, and it's all very controlled. You're using max grip forceps and externalizing this. And then once you tie it up, you can tie it up either with a 3-1-1 or a 1-1-1 with a sliding slip knot. I take out the Chang capsule hooks. You can either take it out through the main wound or you can take it out through the paracentesis. Either or is okay. And with the advantage of the sliding slip knot is, when you pull, you can actually center the bag very nicely rather than a 3-1-1. And and make sure that, we have to bury the knot in. And now fill the eye and then put the toric intraocular lens in the bag. Now, because this person's got a permanently dilated pupil, what I then did is I implanted an artificial iris prosthesis as well in the sulcus, because I thought it was so dilated that I didn't want to do a single pass 4th row pupilloplasty with that. So I used an artificial iris and I made a small PI in the artificial iris. For the artificial iris, what you have to do is, to size it well, you have to take the vertical and the horizontal corneal diameter, take the mean of it and minus 0.5, so that you get a good size. And then I'm putting the artificial iris, which is color matched to the other eye, in the sulcus behind the residual iris, that she's got. And that's the end of the case. So the learning points, from all these cases are initiate rhexis with either a sharp instrument with a needle or a side port blade, and tamponade defect with dispersive viscoelastic, because you want to prevent further vitreous prolapse and remove do limited vitrectomy in the anterior chamber, and use Chang capsule hooks or iris hooks, whatever you're comfortable with, and when you're using the Chang capsule hooks, hold the bend while you're inserting it through the paracentesis, because it separates out quite a bit. So when you hold both the arms together and then insert it, it's much easier. And insert the hooks into the rhexis margin at least 1 clock hour away from the tearing edge. And use max grip forceps. So when to implant a CTR? When it's less than 2 clock hours, you don't need a CTR, is not necessary. You can place the IOL in the axis of the dialysis. 2 to 4 clock hours, you must use a CTR. 4 to 6, you can have CTR plus a Sioni ring or an AMID segment. Or more than 6 clock hours, you can have double Sioni ring or a double AMID segment on either side. And of course, you have sizes of CTR, 14, 14C, 14A, depending on the axial length. And, and always insert the CTR in the area of the zonular dialysis first. And once again, thank you all for your patient listening. And if you have any questions, please feel free to ask the panel.
So from where do we get this artificial iris? Is it available in market or?
No, we get this from Human Optics, which is a company in Germany. It's been around for quite some time. I'm not sure if it's available in India or not. It's made of silicone and it's biocompatible, and it's got 2 models. One is fiber-free and one is fiber. Fiber-free goes in the sulcus or in the bag, and the one with fiber is for scleral fixation.
Thank you. Yeah.
And the measurement for the artificial iris. The question was, how does the artificial iris stay stable in the sulcus and not keep, keep moving forward and backwards. So you have to size it, and because it's behind the stump of the peripheral iris, it stays there. And the way we size it is you measure the horizontal corneal diameter and the vertical corneal diameter and take an average and minus 0.5. And then they give you different sizes of trephine, and you use that trephine and make a small PI at the end and then put it in there.
You mentioned something about the length of the CTR, the size of the CTR.
Yeah.
How important is that to have a proper size? If we have a slightly larger one.
It is always better to go for the larger one, because then you expand the bag well and give it the maximum support.
That doesn't harm.
Sorry?
The larger one doesn't harm.
The larger one is the best.
Okay.
If you have to choose between the three sizes, and if you always go for the larger one.
Thank you.
Yeah. I think if there are no more questions, we have to keep going. Yeah.
Excuse me, sir.
Yeah.
The artificial iris that you use, what is the pupillary size in that one?
It is 3.36 millimeters.
Okay.
And you can actually safely do even a vitrectomy through that.
Okay, thank you.
So the sutures used by you in the CTR ring while suturing it to the scleral opening, what was the suture?
It's a Gore-Tex suture, which is CV8, but it's actually 7.0. It says CV8, so a lot of people think it is 8.0, but it's actually 7.0. It's a fantastic suture. It's biocompatible and it's used in cardiac surgery. You know, it actually enmeshes with the sclera very, very nicely, and it's very, very stable. But the only two precautions that we need to take is, you don't want to tie it too tight, because otherwise you'll get scleral infolding. And if you leave it too loose, every time the conjunctiva rubs over it, it can then erode the conjunctiva and you can have exposure. And the other precaution that we have to take is you got to rotate it through you should not leave the knot under the conjunctiva. You got to bury the knot through the sclerotomy.
Thank you, sir.